Biocare Lifesciences Incorporated is a pharmaceutical company engaged in the distribution, importation, registration, and marketing of various therapeutic products across the Philippines. We at Biocare commit ourselves to service excellence in the promotion and delivery of essential as well as technologically advanced medical products that are within reach of the average Filipino. We pride ourselves in our company core values: punctuality, integrity, commitment, accountability, and this reflects on our service. Our vision is to play a significant role among the pharmaceutical companies in the Philippines, delivering high-quality yet affordable products and services that improve the quality of the Filipino lives it touches. We are dedicated to our mission to be among the top market leaders in our chosen segments by providing qualitative and affordable medicines to the community and year-to-year growth of employees and stakeholders, as well as to develop a young, talented, and experienced workforce. In 2011, Biocare Lifesciences Incorporated was founded by Managing Director Dilip Tiwari and President Kimberly Chua Tiwari. By 2012, we started the distribution of our products to numerous multinational and national companies. In 2013, Biocare registered over 23 products for different segments, and by 2015, we expanded our staff, deploying our new sales force to 17 areas in Central Luzon, South Luzon, and the Visayas region. In 2016, the expansion of the sales force and marketing team continues to the Greater Manila area, Visayas, and North Luzon, and we've moved to the new HQ with a complete rebrand. By 2017, we successfully launched Cefzol, a combination of third-generation cephalosporins and beta-lactamase inhibitor antibiotic. Now, Biocare expands to Cambodia and launched our first inhaler line with salmeterol fluticasone, Salflosol MDI, and Highcare, brand of salbutamol. Biocare has products from reputed pharmaceutical manufacturers around the world, whose facilities are approved by various regulatory boards. And Biocare hasn't even reached its full potential. In 7 years, we've only laid a foundation. Soon, we'll strengthen our reach to the Mindanao region and eventually spread to the whole Asia-Pacific region with a culture of leadership and accountability. Looking forward, we want Biocare to be a corporation that you can always trust. Providing quality, defining life.
Good evening, doctors. I am Paulina Espiritu from MedConcept, your host for this live webinar. To get this forum started, we have with us the Managing Director for Biocare Lifesciences, Mr. Dilip Tiwari.
Thanks, Pauline. Good evening to our doctors. We thank you for accepting our invitation to attend this forum. It has been observed that there are patients who survived the coronavirus and yet still experiencing the symptoms even after they have been clinically tested negative for COVID-19. These are what have been referred to as long haulers. Even as we continue our fight these against this pandemic, the challenges now is on managing COVID-19 sequelae, which varies from mild in terms of fatigue and body ache to severe needing long-term oxygen therapy and lung fibrosis. Tonight, we will learn about lightening the long haul of post-COVID fibrosis. Without much ado, let me introduce our moderator, Dr. Jubert Benedicto. Dr. Benedicto is an associate professor at University of the Philippines College of Medicine. He is the chair for Critical Care Unit, Management Team, and the vice chair for Patient Service Department of Medicine at UP Philippines General Hospital. He is likewise the head of the Public Health and Domiciliary Unit at the Lung Center of the Philippines. Doctor, let's welcome Dr. Jubert Benedicto.
Thank you very much, Dilip, for that kind introduction. And indeed, it's a pleasure for us to join you in this particular forum. I would like to again welcome everyone. And as what was mentioned, we commonly see our COVID patients, of course, once they get in the hospital or once they do have symptoms, they get referred to us. During this time, probably it's through telemedicine. Bottom line, we don't know so much once they get discharged in the hospital. But we do know there are studies to consistently show us that they do indeed have a lot of things in terms of symptoms, and we need to, of course, subsequently manage them to improve their quality of life. And one of the big things as far as this scenario is concerned post-COVID is that of fibrosis. So again, we welcome this forum, and it is indeed a pleasure, of course, to be able to moderate this forum. But before we go and introduce our guest speaker, may I please direct your attention, please, to the question box that you will find in your control panel. Of course, we would like to welcome all questions, all queries, and maybe you can just send in your comments, some questions. We hope to answer as much concern as possible and address this adequately. So I would like to introduce first our speaker to segue now to the scientific session. So I think you know her, and I will introduce her in another manner. She is a distinguished academician, a well-known researcher with a lot of advocacies, and it's always a wonder how she juggles herself being a mother, a wife, and of course my boss in Philippine General Hospital, a colleague of course in the Philippine College of Chest Physicians. May I now welcome to give us a good talk as far as this, as what was mentioned by Dilip, one of the concerns of us clinicians, post-COVID fibrosis. How do we handle them? So let us all welcome Dr. Lenny Fernandez. Lenny, good evening to you.
Good evening, Jubert. I hope the numbers have gone down in the PGH. Not yet.
Well, it's not. It's slowly climbing up, and I guess it's going to be the same as far as other centers are concerned. And definitely, this is one of our concerns: post-COVID fibrosis. How do we handle them? And thank you for accepting the invitation in this evening scientific session.
Thank you, Jubert. So I'm sure your patients now are piling up in your clinic if you're holding face-to-face clinic nowadays. Most likely not. And your teleconsult probably you run up to 11 p.m. So I heard some would run their clinics on telemedicine up to 11 p.m. My goodness. So anyway, this is a very controversial topic, and I can only share with you what I know and what I have dug up. I read so many articles regarding this, and it's really a conundrum right now because there's a lot of things that we still don't know. So these are my disclosures, and this will be our learning objectives for tonight's session. This will be kind of short because our knowledge is not yet really that firm or built up yet. So I'll start with this patient, and actually Jubert and I handled this patient at PGH. She's a 35-year-old female, a nurse, and she had her COVID vaccination already. However, she still succumbed to the COVID critical pneumonia, for which she was put on high flow. And fortunately, she was not intubated, but look at her lungs. So this was on day 18 already. So you can see the GGOs all over the place, all over her lungs. And here we can see some fibrosis already. And there would be some cystic air spaces here as well. And that would be the crazy paving pattern there. And this would be, they would say, some how do they term it? Bronchiolectasis as well as within the bronchial segments. So she remained to be high flow nasal cannula dependent, and the team decided to start her on an antifibrotic pirfenidone on day 21 of her illness. So taking off from that case, I was thinking that how did we get to know more about post-COVID fibrosis? It's actually the knowledge that we have about ARDS since 20 or 30 years ago. So we've been shown this diagram time and again by Dr. Ware and Mathe in the New England Journal and by Dr. Gattinoni as well. And this is very close to our hearts. So we know that when we face our ARDS patients, they come in an exudative phase, and that's why we do all the proning, all the lung protective mechanical ventilatory strategies that we do. But we know that once they're able to surmount this, they go on to the proliferative phase and actually into the fibrotic phase. So this thing we knew already about ARDS. And basically, what is COVID pneumonia when they come into the ICU? It's basically the same thing. It's just that the virus is probably more virulent, or it destroys more tissue. But basically, we're still dealing with ARDS, and that's where our knowledge came from in terms of the fibrotic phase. So if we go back to our pre-COVID ARDS cases and knowledge, this is what we knew then from the autopsy studies that we had. So we know that when our patient comes in ARDS, there would be the exudative phase. And if you look at the days, this was autopsy based. No? So this is knowledge that was really based on what was objectively happening to the lung tissue. So we see now the exudative phase dropping slowly, so that on day 12 and day 21 and up to day 28, that's the time that it's almost nil. And what happens to the proliferative phase there? It starts now at day 3 up to day 7 and then plateau somehow, or still goes up in the succeeding days. Now, how about fibrosis? We see here the fibrotic phase coming in as part of the reaction to the inflammation. It's not that prominent yet from day 0 to 7, but we can see here it becomes now, it starts to build up on day 12, day 21, and then it shoots up really on day 27 and onwards. And how about this other graph here? Now, this is the same database from the autopsy samples that they had. If we look now at the fibrotic column here, the fibrosis column, it is present even on the first week. And then, as I mentioned, it starts to build up on the second to third week and onwards. So what the authors are saying is that even if it really manifests probably clinically or radiologically, the fibrosis from ARDS on day 21 onwards, so that would be the magic number for us here based on autopsy studies, it has already started even early on, but it isn't that prominent yet. So they've looked at all the substances in our bodies, the cytokines and everything, and this is the current knowledge that we have about ARDS in terms of now how it leads on to go into fibrosis. So the cytokines and the substances that are very important in this cascade, as you can see here, would be your TGF beta. And we can see here that it's not just the inflammation that we know, the IL-6 and all those things. We see a lot of interaction here between the alveolo-capillary membrane, as we can see here. And there would be a lot also of the reparative process, the proliferation and the resorption here, as well as the communication between the epithelium and the extracellular matrix, and as well as the mesenchymal cells. And we have here the risk factors, as well as the primary triggering event that led now to the ARDS syndrome that our patients are usually in. So it's not just a single pathway, it's a constellation of everything happening. But there are specific substances there, or chemokines or cytokines, that are more important probably when we now consider the repair process. And for example, that would be your TGF-beta, and later on we will see also the interferon. So these are the things that we know so far. And come COVID, and we saw now a lot of ARDS patients. All our COVIDs in the ICU usually are mostly in ARDS. And that's why we are now handling, because we've managed to at least successfully treat them during the exudative phase, they go on now to the fibrotic phase. And this is one example in one of the articles that we see, that somehow it can become really rapidly progressive. So what are now the substances or the chemokines and the cytokines that are involved in COVID fibrosis? Are they similar to what we had in ARDS pre-COVID time? Yes, they are. They're basically the same. It's just that our SARS-CoV-2 virus, when it now latches on to our ACE2 receptors, would cause a lot more of the endothelial injury, and also a lot of modification in the alveolar epithelium because of that phenomenon of latching onto the ACE2 receptors. So that's why it probably becomes more florid, the ARDS in our COVID patients, compared to the other viruses and to the other pathogens that we dealt with before the pandemic. So we see here now, this is the conceptual framework that we have in terms of what are the biochemical and molecular things happening within the cells and in our body that with SARS-CoV-2 infection leading now to the fibrotic process. So there are the familiar things here, the interleukins, the interferon gamma, as I mentioned, which has supposed to be a protective role in terms of being antifibrotic. And as I mentioned, the ACE2 receptor stimulation would lead to a lot of modification in the alveolar epithelium, so that there would be persistence of your fibroblast, and there would be now an exuberant reparative process that goes on. The microvascular damage and the endothelial dysfunction also plays a big role here as to why some patients would go on into fibrosis and some don't. And that's one thing that we really cannot explain yet as of now. And as I mentioned, the TGF-beta thing is also very important. So aside from that, there are the interventions that we do. And it is also very much proven that our oxygen therapy, for instance, can by itself, with the reactive oxygen species formation, can also lead to more fibrosis through the inflammatory pathway and through also the cellular damage pathway. And the ventilator strategies that we do is very notorious also to also cause more probably an imbalanced repair process as well. And we also have to deal with other things like pulmonary embolism and PICS as well. All these now makes our patient hypoxemic when they now exit our ICU, or we couldn't even remove them from the ICU. So what now predicts among our patients who would develop ARDS from SARS-CoV-2 infection? Will they remain static in terms of, in case they develop fibrosis, that they will stay on like this? Or will they improve? Or will they worsen? And this is probably the $1 billion question, because we still don't know really yet where our patients would go. But it does happen. And I'm sure you see that among your patients. So we see here the timelines that we consider that on the 2nd month or 4th month. But this is also controversial because, as I mentioned, based on our knowledge on pre-COVID ARDS, the fibrosis actually starts even from day 0 to 7, but it is not yet the predominant pathology that is present. So far, from the US point of view, from IDSA and CDC, they would now term the patients who would develop these sequelae. As you know, you very well know the term post-COVID-19. And if they would be the pulmonary constellation of symptoms, then they would be those with persistent pulmonary symptoms. So we have the fondly called term long COVID or long haul if they are able to be discharged from the hospital in the first place. So you know that there is no ICD-10 nor ICD-11 scoring yet or name for the post-COVID syndrome as of now. And therefore, insurances still cannot put a number to it also. And our patients can't even reimburse yet in terms of insurance if that would be the label for them if they remain incapacitated by it. So post-COVID syndrome, post-acute COVID-19 syndrome, and IDSA and CDC put the demarcation time of 28 days. So within the first 28 days, that's still part of your COVID disease or the acute illness. And beyond 28 days, that's the only time you can call it as long haul, long COVID, or post-COVID status. So it's 28 days for the US, and that would be the persistence of the symptoms that you very well know about. So how many would develop that? Again, we still really don't know, but more or less, most of the studies will peg long haulers to be around 10% of all those who would develop a symptomatic kind of COVID illness. How about the UK? They came up with these guidelines last December, so a couple of months back, and their magic number here is 12 weeks. So if your patient still manifests with hypoxemia, with persistent cough or dyspnea, the term for that patient before 120 days after discharge, that patient would still be labeled as ongoing symptomatic COVID-19. And if it's beyond 12 weeks or 3 months, then it is already a post-COVID-19 syndrome. So it depends now where you are in terms of naming as to where your patient would fall into. Now, so I looked into the different cohorts that have been available so far into the post-COVID pulmonary complication state, be it due to fibrosis or not. And this is one of the big ones. So this was a Spanish cohort that was just published a month ago. And they looked at patients only up to 3 months. And they saw that those patients who survived COVID and were followed up after 3 months, so that's 5,300 patients, 59% had CT scan abnormalities. And it was a mishmash of reticular infiltrates with honeycombing, and some still had the BOOP pattern or the organizing pneumonia pattern on their CT scan. Pulmonary function was definitely abnormal in 39%. Fatigue was complained by 38% of the patients, and dyspnea was present around 32%, and cough wasn't prominent already at this time on the 3rd month after discharge. So there was impairment of quality of life, but fortunately, as you can see, many were still able to go to work, despite all these things that were happening to them. And in China, this was just published also a month ago. I think there were 1,000 plus in this cohort. They also saw that after 3 months upon discharge, 62% had CT scan abnormalities. And they noted that there was a reversal in these CT scan findings as well as pulmonary function. There was a reversal back to normal, almost normal, after 3 months in 1/3 of patients. So the dictum for us, it always struck me because the earlier studies always mentioned that, and my patients also, if you would notice that after the 3rd month, it seems to be the turnaround time for many of our patients now to be almost back to normal in terms of their physiology and their functionality. So it seems that is how long the impact of the virus is, and somehow it might be premature for us to consider if it's really a post-COVID state if it is within the first 3 months. No, but in terms now of therapeutic implications, that's really something that we have to think about. And in this study, they also saw the same as the older studies that the risk factors for fibrosis being present on CT scan and manifesting on physiologically was older age, higher BMI, a severe critical condition in the first place, persistence of high viral load, presence of fever, pre-existing disease, and delay in admission. They specifically pegged it that if patients were delayed by 2 days in terms of their admission, that led to becoming an independent risk factor of patients going into fibrosis. So again, that's one thing that we have to consider. And then in the US, this came out this month, and they were just able to follow up around 125 patients, but this was a multi-center study. And you can see that half after 3 months had dyspnea, some had cough, and diffusion abnormality was present in 80% of patients, and a lot of CT scan abnormality of 70%. So it seems CT scan abnormalities still are present, fibrosis is present in 3/4, so that is 62 to 70% among patients coming from the hospital after 3 months. And look at this. The CT scan abnormalities they noted were reticular, so they would still be actually the GGOs, and then going into the finer reticular part, reticular phase in terms of the fibrosis. And the technical term of fibrosis was only present in 21%. So if we now call all the data from the different studies, these would still be the risk factors among our patients would be prone to develop pulmonary fibrosis. So definitely those who had severe infection or a severe manifestation of their SARS-CoV-2, risk factors of previous infection, being male was a risk factor, being older, smoking, comorbidities like diabetes, lung disease, and cardiovascular diseases, and the high need for oxygen and mechanical ventilator use at the start, and evidences also persistence of systemic inflammation. So this would now go with our concept that a higher inflammatory state, probably a more severe disease, would lead to more scars developing and more fibrosis being maintained after the acute phase of the illness. So the next, of course, question to ask is, how will I know if there is fibrosis, and how will I monitor my patient? So one author would recommend this because kanya-kanya, no? Bawat center in the US would have their own protocol. We here in the Philippines don't yet have a protocol for this, but more or less they would recommend that after 3 months, so it's still the 3 months, which is the first landmark for all our patients, preferably, especially if they're symptomatic, lung function should be done, especially our DLCO. Look at the functionality of your patient, so either the 6-minute walk test or if the CPET is available. And you can do, of course, now a plain CT scan or a high-res scan to look now at the findings. So next would be, what now will you look for to say there will be fibrosis? And if our contention before of if patients are in ARDS and we consider fibrosis to be starting, when will we say that the fibrosis now will be significant enough? Do the radiologists have a cutoff? Do they have criteria? They don't have yet. No? So they have the TSS, the total severity scoring for radiologic findings in COVID. But in terms now of the degree of post-COVID fibrosis, they don't yet have a consensus regarding this. So as long as there would be manifestations now of our usual fibrosis of reticular opacities, so I outlined it here, what would be those, the reticular opacities, even the presence of the GGOs and mosaic attenuation or the crazy paving would still now be part still of the process of going into fibrosis. But for us to say that technically fibrosis talaga to, then that would be your cystic findings there, the honeycombing, the bronchiectasis, so this one here, and your reticular opacity. So those, and the parenchymal band traction. Meron ba dito? Parang meron dito. Yeah. So those now will be our findings now of fibrosis. So these are the cystic changes that you look at your CT scan and the bronchiolar irregularities, and these are now signs of air trapping as well. So those now are the findings that will tell you there is fibrosis. And how do we now proceed with treatment? Now, if you're able to confirm that there is a presence of fibrosis by CT scan, for example, will you be able to do that by X-ray? It's kind of hard, you know that, because especially if you still have the GGOs there, then the X-ray will not be sufficient unless probably you do see now the bleb developing or those cystic lucencies developing at the lower lung fields, probably, that can be indication of presence now of fibrosis happening. So the next thing would be, when do we start treatment? If, for example, you now have the diagnosis that, yes, it seems there is significant fibrosis in my patient happening. So knowing that it started early on, how early should I start? Now, here is the dilemma, because our post-COVID fibrosis definition supposedly, or post-COVID state, should be done on the 3rd month after discharge. But that would now be like, it's already there. So why can we not be preemptive and consider it early on so that we can start treatment to prevent further fibrosis from happening? So this is a dilemma that we still don't have any answer to as of now. So definitely, if we're dealing with a fibrotic disease, then the treatment will be antifibrotics. It's like it's quite logical. But we have to think now, the consideration is in UK, for example, and we'll see that steroid study later, that patients, after they have the acute phase of the SARS-CoV-2 illness, or ARDS for that matter, not all, some will be quite dyspneic or hypoxemic. They don't have PE. But when you look now at their CT scan findings, it won't be the typical UIP or the fibrosis that we're talking about. Some would actually have more of the pathology still of the BOOP, or the cryptogenic organizing pneumonia, or the organizing pneumonia. And that's why there is the rationale, as you would know, for steroid use also for these patients in the relatively post-COVID state, or the post-ARDS COVID state, because it's not just fibrosis that's present, but there is also the presence of the cryptogenic type of organizing pneumonia pathology that has been seen. But if our patients do manifest with fibrosis, then we get now the conceptual framework in terms of treating it from our knowledge of UIP, and that would be our IPF, or the usual interstitial pneumonia. And with that, it has been consistently shown that antifibrotic treatment can work even for our UIP patients. And that's why we have extrapolated it to use for post-COVID fibrosis. And so far, the medications that are available and have at least shown good data would be our antifibrotics, such as nintedanib and pirfenidone, from our knowledge of UIP or IPF. So how do these medications act? So we know that our nintedanib, for example, is a TKI, and that's how it now would stop the exuberant repair process. So it would block here mostly our VEGF here through the tyrosine kinase pathway here, whereas our pirfenidone acts in a different manner, or in a more encompassing manner. So by inhibiting that thing that I mentioned, the TGF beta production, and it causes now a down signaling of the repair pathway beyond that. And in terms of IPF, you know the big studies already supporting nintedanib and pirfenidone. Both have shown that they do improve lung function and functionality as well, although they haven't really exactly been shown to substantially decrease the radiologic findings of UIP among our patients with UIP. For example, pirfenidone has the ASCENT study, which showed that there was 193 ml improvement in FVC when it was given for 2 years. And these are now the recent meta-analysis on UIP with the use of antifibrotics, such as your pirfenidone and your nintedanib, and the newcomer pamrevlumab in UIP. So they have been consistently shown, and in our IPF guidelines, for example, there is a conditional recommendation for the use of these antifibrotic agents if we're going to use it for UIP or for IPF. Then now what we did was to extrapolate our knowledge about fibrosis and repair to the post-COVID state from our knowledge of UIP and IPF. And therefore, we are using repurposed drugs. And it has been our dilemma again for the past 2 years, because we are what the epidemiologists would call in a clinical equipoise, where we virtually know nothing about it, and we are now surmising based on our theoretical knowledge and what we know so far. For example, in ARDS, we're extrapolating it now to this phenomenon that we have. So when we do that, then we have to be very careful in terms now of administering or proposing the use of these drugs, because we might engender more harm if we are now like we are pushing towards a certain drug, for example, when we don't have much data or we don't have much basis, since everything is, it can be given virtually at this point in time. So are there trials going on? Yes, there are, for nintedanib, for pirfenidone, and you've been exposed also to the Light 100, the deupirfenidone trial that is ongoing, in which we are participating here in the Philippines. So let's go now to the data, to the trials that are available, the clinical trials. So the newest, of course, I'm sure you know about this, would be the UK NHS trial on steroids for post-COVID fibrosis. Now, you have to be careful as to the situation or the scenario or the population that was considered in this setting. So this was an interventional trial, but it had no control. So this was basically a prospective cohort study. What they got were patients 6 weeks after discharge, and the patients were assessed by a multidisciplinary team and deemed to have persistent interstitial lung disease based on CT scan findings, and they also had persistent non-improving symptoms at the time. So remember, that's 6 weeks, so that's 1.5 months after discharge. And if you look at the database of these patients, the ones who were included, they most of them were oxygen dependent when they were discharged, no? But eventually at the 6 weeks after, many of them were already not. And then 16% underwent intubation, and their lung function was poor, 60% only in terms of the DLCO. Their SATs were 95, and 66% among them showed organizing pneumonia. So this is what I'm saying, that it was not fibrosis that was the predominant pathology that they saw on CT scan 6 weeks after discharge. What they saw among these patients was more of the organizing pneumonia. And from what we know about organizing pneumonia, it is definitely very steroid responsive. So what they gave was prednisolone at 0.5 milligram per kilogram, so that they were giving it at 27 milligrams average. And then they did a rapid wean, so that this is their organizing pneumonia protocol. So they gave it for 3 weeks, the oral prednisolone. No comparator. And what did they look at? Baseline to 3 weeks after, to reassess now the outcomes. And their outcomes were lung function test, the LCO, as well as functionality through the 6-minute walk test. They did not look at CT scan, so that was not part of their outcome. And they saw there was a significant improvement in majority of the patients. It was statistically significant among those who were given prednisone or prednisolone. So that would be the setting of that study. The next study that was just published last week was already nintedanib in Japan. So what they did here, on the other hand, was, this is interesting, because they got ICU COVID patients on intubation and on assisted mechanical ventilation. And what did they do? They gave nintedanib at the start, day 1 of admission in the ICU, day 1 of intubation, and they gave it for 28 days at 150 BID. And what was the control? So they administered it from, I think, July to September 2020, and their control was the historical group of April to June, so 3 months. So that was their control, and they looked at mortality as their primary outcome. It was not significant. So there was no difference between the group given nintedanib to those who did not. They looked also at mechanical ventilation duration. So it was significantly shorter for those who were on nintedanib. And in terms of also CT scan abnormality, they looked at that, and there were less fibrosis and other findings like the GGOs, for example. They were much less statistically, significantly among those who were given nintedanib. Adverse events were the same. So this is interesting because they looked at that theory that we were talking about, that right from day one, give already your antifibrotic, and this was the result of their study. So next, now we'll go to the antifibrotic called pirfenidone. So everybody has been scrounging around for this for your post-COVID patients. And finally, thank you very much. It will be available now in the Philippines through Biocare. So what is pirfenidone? So as I mentioned, it mostly now inhibits the production of the TGF-beta, which now is the main, we can call it the main substance that regulates now the repair process. So it now regulate, or it lessens now the downward pathway in terms of repair. It reduces the overall production of the different types of cytokines, such as your TNF alpha and your interleukin 1. So overall, it is, aside from being antifibrotic, it is an antioxidant and anti-inflammatory as well. Based on how we gave it in UIP, this is how they would recommend us to also give for our post-COVID fibrosis patients. So we know that the preparations that are available from the originator is the 267 milligram as well as the 801 milligram. You're supposed to introduce it gradually, building it up, so that you will lessen out the adverse effects. So day 1 through 7, you start off with 267 milligrams TID, and then later on you build it up to 2 caps 3 times a day, and try now to reach the 801 milligrams TID formulation or dosaging till you go on in terms of your treatment. So for UIP, we know that we give it for 6 months or 1 year and even 2 years. So in COVID-19 pulmonary fibrosis, are there studies using pirfenidone? So I looked far and wide. There has been no interventional study yet. So we are waiting for those that have been registered in the clinical trials. What I've seen were case reports though, and the biggest would be the one done in Egypt, which had 5 patients. And look at how they gave pirfenidone. Kanya-kanya din, no, in terms of how they gave it. So for example, one case report now started pirfenidone on the 30th hospital day. So the patient was still inside the hospital at that time with fulminant fibrosis, and they gave it at the 2,400 milligram, the highest dose possible after reaching it, after building it up. And with that patient, they saw a significant decrease in the fibrotic infiltrates on CT scan after they gave it for 60 days, I think, 60 days here. And then in the other study also, they gave it at 267, as you can see here in the slide. And then they gave it only for 8 weeks. And then they looked at the CT scan again of the patients and their functionality, and they saw significant improvement among the 5 who were given. This other case report gave it 12 weeks after the discharge. So this would be the formal post-COVID definition. And then he gave it at the 2,400 milligram per day dose. So the other one, on the other hand, started to give it on the 6th week and continued it again for another 12 weeks. And again, they saw, I'm sorry, here the author gave it immediately on discharge and continued it for 6 weeks. So here it was quite limited compared to the UIP. Many of them just gave it for 6 weeks to 8 weeks. And then the other study gave it for 3 months. So there are differences, as you can see, as to how it was used. So if we go now to the molecule itself, as we mentioned, the mechanism of action is totipotent, just like your steroid, but this time targeted more towards the decreasing the repair, and that is the dose. And the warning would be, of course, not to give it if your liver enzymes are very elevated. Usually we have the cutoff of 5 times, not to give it if the liver enzymes are 5 times elevated. So in some of the patients that I've given this, yes, diarrhea and abdominal pain are common adverse reactions to the drug, and what we did was just to lower down the dose. And then remember that there can be drug interaction, and it is not yet, of course, tested for pregnant and lactating women as well as for children. So that's our knowledge so far in terms of birfenidone for antifibrotic treatment for post-COVID fibrosis. Now, I'm sure you're dealing with a lot of these patients, and as you mentioned, long haul would not just affect the lungs, but affect the whole body and the psyche of the patient, and that's why holistic care is needed. So it would be good that in your institutions, you'll be able to put up your own post-COVID wellness service for your patients, because they continue to need medical care as well as the overall care of their well-being. This is one proposal in terms of how we can go about diagnosing and or approaching post-COVID fibrosis. So in this pathway, if you can take a look at, if you will note, they had the cutoff of 3 weeks. That beyond 3 weeks, if your patient is still symptomatic pulmo-wise, for example, and your X-ray probably, and thereon your CT scan will manifest now with fibrosis, then that's the time now you would consider treatment. And for example, our CT scan would be very useful if you're going to do a CT angio to rule out other possibilities of hypoxemia, such as pulmonary embolism. And I'd like to emphasize here that while knowledge is scarce, then it's good to get together, form a multidisciplinary team, be friends with your radiologist, and then be friends even probably with your rheumatologist if needed, if they are familiar in terms of using antifibrotic drugs, because this is the way to go. Our knowledge is really very scarce right now. So we have to lean on towards each other to help our patients. So it's a new entity, the post-COVID fibrosis. A multidisciplinary approach is warranted, I think, in this kind of a setting. There is a theoretical basis to using antifibrotic treatment, and at least now the small studies that are starting to crop up would show that our antifibrotic treatment may have an effect. As to when to start it, how long, what outcomes to measure, it's really still up in the air right now. And I hope in a month's time, hopefully we'll have more knowledge about it. Thank you.
So thank you very much, Lenny, for that very good and extensive talk on something that we, as what you mentioned, we still are yearning for more studies. And as what you repeatedly mentioned, it's one thing in terms of, proving the concept and then subsequently watching if it will really work on our patients. So again, I would like to remind the participants, if you have any questions, please type in the Q&A box. So there's this first question. Does pulmonary fibrosis increase possible chances of having serious complications from COVID-19? So I guess it has something to do, I'm just guessing it has something to do with the other complications post-COVID. Will fibrosis, uh, port, say that your patient is going to be worse?
Well, in terms of the functionality and the well-being of the patient, definitely it will have an effect. But whether per se it is a risk factor leading, for example, to pulmonary embolism, to other complications like cardiac or neuro, then probably there won't be a direct effect. But because of the impairment in terms of the dyspnea and being deconditioned and not being functional, that definitely can create a lot of complications.
Okay, so I would like to emphasize as well what you mentioned earlier, na maskin sa simula pa lang, let's temper our interventions knowing fully well that they can contribute the fibrosis. You mentioned making our ventilator setting, of course, lessening the chances of ventilator-induced lung injury, not really aiming for supranormal O2 saturation. That will probably help as well. there's this question: what if you cannot monitor the 6-minute walk test? Will you go on and just base it on the patient's, I don't know, patient's symptomatology, if really your intervention like perfenidone is really working the way it should?
Yes. So, for example, in that antifibrotic study, it was a problem for them. They couldn't do the 6-minute walk test for their patients, so they had to rely, for example, in that study, they relied really just on the DLCO and the pulmonary function test. But I think even just doing the MMRC, the dyspnea scoring, can mean a lot as long as you have a parameter to work on to gauge the effectivity of your treatment.
If it will work, when will you see it? I mean, in
So,
terms of the
yeah.
symptomatology, etc.
So from the case reports, it was 6 weeks, no,
6
to
weeks pa
eight
rin.
weeks.
Oh,
But if
okay.
we go with the knowledge of UIP, then that will be 6 months minimum, no, for you to see the outcome. Kaya lang, ang malaking debate ngayon is will the fibrosis from that viral illness, will it lessen with time by itself? No? So will the fibrosis lessen with time? So they looked at MERS-CoV, they looked at SARS-CoV-1 epidemics, avian flu epidemics before, and they saw it did lessen with time without any intervention. No, but around 5%, for example, in the MERS-CoV-2 had persistence really of fibrosis up to 2 years and even 5 years down the line.
Okay. I'm just struck by the weird dosing per capsule.
Yeah.
267 and 801. Bakit ganun?
Ewan
Napaka-obsi
ko nga
naman na
ba
nag-invento ng kapsula na
talaga.
yon. Oo.
I
So,
wasn't
walang
able to dig up on
explanation.
that. O walang explanation nga. Siguro nga
I
talaga
mean,
yung
why not
potency nila.
800 to 250 na lang, 'di ba? Para I thought there was some explanation. There's another question here. Can you give it via NGT?
So,
Perfenidone?
the pirfenidone, yes, inaalaw daw nila. Ang problema nga was with nintedanib, di ba? Kasi liquid yung loob ng capsule. But
Correct.
in that
Correct.
Japanese study, they gave it through NGT.
Wow.
No? They were
Okay.
allowed to give it. Kasi day one pa lang ang intubated, binigay na nila. So all the more with pirfenidone, yes, you can give it through NGT.
Another question here is, you mentioned when to start perfenidone. You mentioned earlier yung magic number na baka nga 3 months. And then, of course, there are signals that why not start it earlier. Ang tanong naman ng iba, when to stop? When do you
Yun,
say
so
na, hindi, 6 months ba? Yun na, tama na yun. Kung ano yung pulmonary function niya, yun na yun.
So ito nga isa ko pasyente ngayon. Doc, inuubo na ako ulit. Naka 4 months na kami. So may improvement na. Natanggal ko na yung tracheostomy. Doc, inuubo ako ulit. Parang hinihingal ulit. Gusto na naman. Pero kung titingnan mo yung CT scan, grabe. Nandun pa rin talaga yung mga reticular infiltrates sa multilobar pa rin. So anong
mahirap.
sagot doon? Mahirap. Si case reports that I showed you, gave it just for 6 to 8 weeks, no? And then when they got na the functional improvement and a little bit of lessening on the CT scan, they stopped it, no? But again, kung basis nga natin, si UIP yung treatment natin,
Correct.
talagang
Correct.
minimum tayong 6 months, no? Hanggang maintindihan natin.
Is there any danger for giving it long term? Meron bang dapat i-watch out, sa long term na? Because you mentioned escalating yung dose, di ba, para ma-tolerate ng patient.
So it's
Anything
more
there
really of, so they saw it's a little bit, it's more of the adverse events, but as to yung effect niya on the repair processes, kasi yun ang hinihit niya, di ba? If there would be other effects on the other organs,
Yes.
they didn't see. Merong isang parang ophthalmologic, no? Pero by itself,
okay.
ginagamit naman siya for other eye disorders, but it led to some eye disorders for some. May ibang case report na gano'n.
Okay, so
Long term.
maybe as what you mentioned talaga, kailangan i-monitor. It's you who will decide with the patient, susubukan pa ba natin. There are persistent queries here in terms of your practice. We usually, of course, we give steroid during the COVID, di ba? During the COVID. Steroids yan. tapos dinischarge mo na yung patient. You mentioned kasi yung ubo-ubo, tapos let's say the patient, may konting hingal-hingal. Okay raw bang magbigay ka na lang ulit ng isa pang course ng steroid? Kasi pakiramdam mo, maganda siya nung may steroid eh. I mean, building on yung sa sinabi mong organizing pneumonia framework, will it be acceptable na, start ako ulit ng steroid regimen and then possibly magsa-start na naman ako ulit, let's say after 3 weeks nung you mentioned yung tapering dose?
So, depende na kung anong hinihit natin. So, I just came from the ECMO na forum kanina.
Mhm.
No,
Yes.
I was very surprised, si Professor Schmidt. So, they don't use antifibrotics in France. What they do,
okay. Yeah,
what they do sa ICU setting na kung they feel na meron talagang fibrosis then they base it on the old ARDS studies. They would give high dose of methylprednisolone. Ang taas ng dose niya 250 for 7
BID.
days. Yeah, 250 per day. So
Per
yung
day.
125 na BID. So parang pulse, no? And then give it for 7 days and then drop to 125. Yun ang regimen nila for 7 days and then taper off. Tapos papatagalin nila. So those are the and he admitted na they're basing it on the older studies on ARDS before with fibrosis. No, yun ang basis ng kanilang protocol doon. So, giving steroids after discharge kung halimbawa bumalik yung symptoms. So, the UK study that I mentioned, anong protocol nila doon? They assumed na merong organizing pneumonia. They confirm muna na may organizing pneumonia. They started it again on the 6th week.
6th week.
And then gave it for 3 weeks, no? At the dose that I mentioned.
So, ano pa talaga? Hindi pa talaga natin ma-pin down, yung tamang approach. Mahirap i-unify, Kasi nga naman, if you are faced with the patient, complaining of these things, you mentioned yung easy fatigability, kahit yung cough nila, napaka-bothersome. Wala kang magawa. Tapos, as what you mentioned, yung take-off case mo, yung 35-year-old, I'm just going to be frustrated, Nurse ka, 35-year-old, pag hindi mo siya matanggal sa oxygen, 'di ba? Grabe yung impact sa quality of life nung individual na 'yon, no? So I
yung
think
case na yan, nasa 5th week na tayo of pirfenidone and she was discharged 2 weeks ago and lo and behold, she's off O2.
Wow, okay.
Hindi ko pa na-repeat ang CT scan, but I gave her na the leave na 1 year to. You'll be on leave from work for 1 year, no? Considering yung again on the premise na para siyang UIP na pathology. At tapos ang isa pang nangyayari nakikita ngayon yung mga honeycombing and yung mga bronchiolitis na nangyayari. People are having obstructive airway diseases then. That's part of the post-COVID state din na nakikita nila ngayon.
Na hindi na re-reverse. Tama ba?
So I mean through time? Kasi parang ngayon lang nila nakikita.
Okay,
so we
so
don't know how it will be.
Talagang kailangan follow up pa. We are being outwitted kumbaga nitong disease na to, no? Napipin down mo pa lang kung how you approach inpatient with the trial. Ito naman ang problema mo, yung survivors niya, no? Mahirap ipin down, no? Kung ano ba talaga yung tamang formula, as what you've mentioned in your concluding slide, when to start, how do you monitor, when to stop, as what the audience here are asking us. I think na-answer na rin ni Lenny itong in terms of pirfenidone as main treatment lang daw for UIP and IPF. Tama ba ako? You showed the slide in terms of... Yes, okay.
So there's a trial where it's combined with N-acetylcysteine, but it didn't matter. Because di ba iba sila mechanisms of action?
Correct.
So meron pang trials na kinombine yung dalawa. So they saw na more yung adverse events but it didn't lead to better outcomes.
Okay. Basing on your practice daw, is it advisable to start pulmo rehab as soon as possible even if the patient is intubated? Siyempre, yun yung quick answer doon. Yes. May follow-up question dyan. Yung how. Oo nga. That's your
So,
rehab daw. Go to the ICU. Oh, intubated
di
ka.
ba?
Florid, COVID positive ka to. Oh.
So, sabi nga ni Professor Schmidt kanina din sa France, they don't have a good pulmonary rehab program because they are undermanned.
Okay. Pero ideal,
Okay.
yes. You
Ideally,
would
yes.
recommend
Yes.
it. Nakalagay dito, in general, how long? Even after discharge, how long is yung usual daw na pulmonary rehab that you would expect the patient, okay ka na.
Then we can go with our usual na mga dictum for COPD also. That would be minimum sana of 6 to 8 weeks.
6 to 8 weeks. Okay, minimum. Okay. How about your experience in terms of COVID daw with asthma? Are they more prone to the development of fibrosis?
Wow, nice question. So far kasi maliliit lang yung cohorts nga nakita natin, wala pa nakitang signal regarding that.
Tapos mayroon na atang mga nilabas pulmofibrosis, asthma, COVID, asthma does not matter in terms of severity unlike yung ibang comorbidities in
Yes,
terms of
yes.
outcome. Question on pirfenidone, what do you do po if you miss a dose or a dose for 1 day or 2 days?
Oo.
Ano ka ba? Magre-reload ka? I think that's the main question kasi sabi mo
Oo.
escalating dose, di ba?
Yeah, oo. So no need naman to reload, just stick to the dose that you were supposed to have.
Any comment on the use of budesonide for dyspnea for COVID
Oo.
patient?
So I'm sure you're familiar with the two studies, no? Tapos ano din sila eh, it's an interventional na prospective cohort na wala ding control, 'di ba? So yes, it did show some improvement in terms of the function, pero hindi nila, if I remember right, no? Tama ba ako? It didn't look into the lung function also. It didn't measure really the spirometry, 'di ba?
Yeah, yung stoic
Yung
ata to
post.
tsaka principal
Yeah, so
study, no? The
yes,
stoic
yes.
and principal. And then I think that's the main conclusion there na sinasabi raw nila may protective effect and they're using it more, to possibly have better outcomes in terms of these patients. But I agree with you, yung mga na-monitor in terms of lung function, yun yung limitation ng study. May pahabol po. How about post-TB fibrosis? Do you think daw pirfenidone will have an effect? So hindi na to COVID, post-TB fibrosis na. Oh.
Alam mo, that's an interesting question nga, no? Kasi definitely, it's the same pathway that our lungs would go through, no? In terms of repair. So yes, there's a possibility it can work for that, no? Pero what is post-TB fibrosis? It's not the same, I think, no? As our post-COVID na fibrosis. Iba ang effect ng tuberculosis, 'di ba? Ang dami ng structural na defects, more
Tsaka
probably
mas
the
matigas siya.
bronchostatic type.
Sabi nga raw nila.
Yeah.
It's a
Diba?
harder form of fibrosis. Hindi siya yung medyo daw malambot. Meron ulit pahabol. Last na po ito. What is the mean survival based on your review on IPF daw without, let's say, giving nintedanib or pirfenidone? Survival, they're asking survival effect.
Survival, 2 years na study, parang kapag wala, survival is only around 40%. And with that, it was lower down, I think, to around 30% or something. Meron statistically significant difference siya, no?
So
Looking
the
at
potential is there definitely in terms of impacting yun nga na-mention natin, in terms of the quality of life and then in this case, maskin survival. I think, Lenny, that's the last question before I let you go. Do you want to have some last words in terms for our audience, mga take-home messages?
So, napagod na ako dun So, well, of course, be safe. And then in terms now of pagod na tayo lahat sa inpatient care, di ba? Tapos many of you hid and don't do outpatient face-to-face clinics. But we have to remember that we have to continue taking care of them. And then I'm sure you have some horror stories din na nariri-admit nga ang pasyente So let's regard the SARS-CoV virus as a worthy enemy, no? Na its effect can still even go beyond that hospitalization, and let's consider how our patient is. Thank you.
Okay, thank you, Lenny. And with that, I would like to thank, of course, the audience. You mentioned horror stories. Ako yung horror certain. Anyway, I think the story ko yung spokesperson. Main lesson here that we would like to highlight is, of course, where our mind should be open. Let science speak. Yun na nga. We are at the crossroads. Actually, maraming study based on concept, maraming framework na pinupush, and it might have been, built on previous diseases. We can always argue, hindi naman yan COVID eh. But definitely, as what Lenny mentioned, yung sequelae ng COVID, hindi biro, especially coming from the patient. And maybe at this point in time, even if we are demanding for robust trials, walang masama kung subukan natin sa patients, because at the end of the day, they should be the one benefiting. So I think as health workers and professionals, it's just our duty to, appraise the literature and possibly, as what you mentioned earlier, ito bang profile ng patient sa harap ko? Katulad ba ng mga study for me to try out this medicine? So again, thank you, Lenny, for that. Allow me now to turn over the virtual floor to the product and sales managers for Biocare Lifesciences. May I call on Mr. Michael Christian Perey and Mr. Mark De Vera for the next segment. Again, thank you for your attention, colleagues.
Thank you for that, Dr. Jubert, and thank you, Dr. Lenny, and to all the doctors who stayed on. After that scientific talk, we want you to rest your mind and enjoy this quiz segment. We will flash a question on the screen, and all you have to do is write the correct answer on the question box. The first person to send the correct answer after the timer has stopped will receive these items: a pulse oximeter or a UV lamp. Multiple choice questions, simply answer with a letter of your choice. Just a reminder to write your answer on the question box. So Sir Mark, do the honors of reading the first question.
Thank you, Sir Mike. Good evening, doctors. Here's the first question. Which of the following statement is correct on idiopathic pulmonary fibrosis? Letter A. Idiopathic pulmonary fibrosis is the most common type of pulmonary fibrosis. Letter B. It is a disease that causes scarring, fibrosis of the lungs. Letter C. Lung damage from IPF is irreversible and progressive, meaning it gets worse over time. And letter D, all of the above. Timer starts now. To show the audience the correct answer, letter D, all of the above. And the first person to get the correct answer is Dr. Pamela Velasco. Congratulations, Doctora. You won a pulse oximeter.
Congratulations, Doctora.
Congratulations, Doctora.
All right, here is the next question. Biocare's brand of pirfenidone, Pulmosis, is available in what preparation and SKU? Letter A, 267 milligrams capsule and 801 milligram tablet. Letter B, 267 milligram tablet and 801 milligram capsule. Letter C, 216 milligram capsule and 801 capsule. Letter D, 267 tablet and 801 tablet. You may key in your answers now. And let us show the correct answer. The correct answer is letter A, 267 milligram capsule and 800 milligram tablet. So the first person who got the correct answer is Dr. Milanen Flores. Congratulations, Doctor.
Congratulations, Doctor.
You won a UV lamp.
Okay. Moving on, here's another question for you doctors. True or false? Pirfenidone is an oral antifibrotic agent with a multiple effects such as regulation of pro-fibrotic and pro-inflammatory cytokine cascade and the inhibition of fibroblast proliferation and synthesis of collagen, which is a standard therapy for lung cancer and moderate idiopathic pulmonary fibrosis. Letter A true, letter B false. Timer, please. All right, let's show the audience the correct answer. Letter A, true. And the first person to get the correct answer is Dr. Ronald Fajardo. You've won a pulse oximeter. Congratulations, Dr.
Doctor. And doctors, we have more couple of questions. Next is a trivia. As of September 9, 2021, the highest ever single day dose COVID-19 cases in the country since the pandemic started is letter A, 20,310, letter B, 20,741, letter C, 22,820, and letter D, 22,310. Timer starts now. And let us show the correct answer. The correct answer is letter C, 22,820. And the first person who got the correct answer is Dr. Patricia Pinta. Congratulations, Dr. You won a...
Congratulations, Dr. And finally, we're down to our last question. And aside from pulmonary fibrosis, pirfenidone, Biocare Lifesciences also marketed the COVID-19 drug. Letter A, remdesivir. Letter B, favipiravir. Letter C, tocilizumab.
Mike, can you finish with the question, sir?
Now.
And letter D, all of the above. Timer starts now.
And the correct answer is letter D. The first person who got the correct answer is Dr. Vinci Orhel. Congratulations, Doctor. You have won a pulse oximeter. Now, congratulations, doctors, and may we request to for all the winners to please write your name and address on the question box in order for the tokens to be delivered to you. We hope you enjoyed that quiz segment, and with that, let me call on our business unit head for Biocare Life Sciences, Mr. Ronald Palacio.
Thank you, Mike and Mark. Hello, doctors, and good evening. Thank you for taking the time to join our webinar. It is our hope that the topic we presented gave you more insights and is relevant in your clinical practice. On behalf of Biocare Life Sciences Incorporated, I would like to thank our speaker, Dr. Eleni Fernandez, for sharing with our attendees how to lighten the long haul of post-COVID fibrosis. Our gratitude as well to Dr. Jubert Benedicto for moderating tonight's forum. To our partner agency, MedConcept, thank you for organizing this webinar. Before we end this webinar, we would like to invite everyone to please like and follow the official Facebook page of Biocare Life Sciences as flashed on the screen and have a chance to win one of the 3 Littmann Stethoscope Classic 3. Winner will be announced and posted tomorrow, September 11, Saturday at Biocare Facebook page. Pulmosis Biocare brand oral pirfenidone is available in 267 mg capsule and 801 mg tablet. And to avail it, hospital need to secure application for compassionate special permit. As a final note, we would like to request our participant to answer a brief survey before you leave the webinar. On your screen is QR code and link. Please scan the QR code and type the link on your browser, whether Google or Safari, and begin answering the survey. Once you have accomplished the survey, you will automatically receive your e-certificate, which you can download. You will also receive a copy of the e-certificate in your email. The survey is open from 7 to 11 p.m. only, so don't forget to accomplish the post-webinar survey form so as to facilitate your certificate of attendance. Once again, thank you, doctors and healthcare partners, for spending the evening with us. Stay safe, everyone.
Biocare Lifesciences Incorporated is a pharmaceutical company engaged in the distribution, importation, registration, and marketing of various therapeutic products across the Philippines. We at Biocare commit ourselves to service excellence in the promotion and delivery of essential as well as technologically advanced medical products that are within reach of the average Filipino. We pride ourselves in our company core values: punctuality, integrity, commitment, accountability, and this reflects on our service. Our vision is to play a significant role among the pharmaceutical companies in the Philippines, delivering high-quality yet affordable products and services that improve the quality of the Filipino lives it touches. We are dedicated to our mission to be among the top market leaders in our chosen segments by providing qualitative and affordable medicines to the community and year-to-year growth of employees and stakeholders, as well as to develop a young, talented, and experienced workforce. In 2011, Biocare Lifesciences Incorporated was founded by Managing Director Dilip Tiwari and President Kimberly Chua Tiwari. By 2012, we started the distribution of our products to numerous multinational and national companies. In 2013, Biocare registered over 23 products for different segments, and by 2015, we expanded our staff, deploying our new sales force to 17 areas in Central Luzon, South Luzon, and the Visayas region. In 2016, the expansion of the sales force and marketing team continues to the Greater Manila area, Visayas, and North Luzon, and we've moved to the new HQ with a complete rebrand. By 2017, we successfully launched Cefsul, a combination of third-generation cephalosporins and beta-lactamase inhibitor antibiotic. Now, Biocare expands to Cambodia and launched our first inhaler line with salmeterol fluticasone, Salflosol MDI, and Highcare, brand of salbutamol. Biocare has products from reputed pharmaceutical manufacturers around the world, whose facilities are approved by various regulatory boards. And Biocare hasn't even reached its full potential. In 7 years, we've only laid a foundation. Soon, we'll strengthen our reach to the Mindanao region and eventually spread to the whole Asia-Pacific region with a culture of leadership and accountability. Looking forward, we want Biocare to be a corporation that you can always trust. Providing quality, defining life.
Another summer day is coming gone away. In Paris, Rome, wanna go home. Oh no. Maybe surrounded by a million people, I still feel all alone. I wanna go home. Babe, I miss you, you know. I've been keeping all the letters that I wrote to you. But each one of mine, too. I'm fine, baby, how are you? Would send them, but I know that's not enough. My words were cold and flat. You deserve more than that. Another airplane, another sunny place. Lucky I know I wanna go home. I got to go home. Let me go home. Just too far from where you are. Gotta go home. Feel just like I'm living someone else's life. It's like I just stepped outside and everything was going right. I know just why you could not come along with me. 'Cause this was not your dream, and you always believed in me. Another winter day, it's come and gone away. Either Paris or Rome, but I wanna go home. Go home. I'm surrounded by a million people. I still feel alone. Let me go. If I miss you more, let me go home. And my home, baby, I'm young. Wanna go home. Let me go home. And I'll be alright. And I'll be home tonight. I'm coming back home.
Ending webinar in 3, 2, 1.